like to invite here on the stage with a louder and louder round of applause, Dr. Deepak Agarwal, who is the chairman of computerization and IT in AIMS. Can we have a huge round of applause from Dr. Deepak Agarwal? Welcome, sir.
Good afternoon to all. My talk is slightly different from the usual talks on education. Here I'll be talking about healthcare and how we have managed to improve the healthcare provided in a government institution using information technology and educating the staff and the public again using information technology. Yes, niche wala, go back. So I am actually a neurosurgeon. I'm additional professor in neurosurgery at All India Institute of Medical Sciences, and I have no background IT skills. So I had to educate myself first to take on this task. As it happens in various organizations, you are given additional responsibilities, and if you have interest, you can obviously make it into a wonderful thing. And I had interest in IT, so I decided to educate myself. So this is the talk I'll be giving, is cost-effective IT implementation for healthcare. And when we started, and this is just 3 years back actually, at All India Institute, there was no IT implemented. And this is true for a lot of institutions across the country. Healthcare is specifically prone to it because although IT has permeated a lot of service sectors in the government as well as the private, healthcare remains, the Achilles heel of IT implementation. And it's not because of dearth of money or dearth of resources. AIMS itself has a budget of more than 2,000 crores every year. So it's more than the health budget of a lot of states in India. So there is, we are not lacking in the amount of money we are getting. I think it is a lot of factors which actually cause failure of IT implementations. And software costs are just one of them. It is additional costs which come into the picture. And what happens is, and I realized it when I had a meeting with the Director General of Health Services some years back, and we had gone to him to tell him, sir, why don't we do some IT training, IT implementation in the hospitals? He said, okay, we'll just take a vendor and ask him to do everything. So I told him, sir, it's not the vendor, we have to ourselves do something about it. He says, no, if you're paying the vendor, it is the vendor's responsibility to do it. So there's a complete disconnect in terms of, if you think you're paying somebody or something, you expect the whole thing to be done. Unless there is a buy-in by the stakeholders, which are the people working in the hospital, the patients, and it's similar to the school system also. You can be implementing any kind of strategy. If the students are not ready to accept it, or the teachers are not ready to accept it, that strategy is going to fail. So I was just listening to all that CC, although I don't understand it. But it is similar across all domains. That if these stakeholders do not buy out, or they are not totally into with whatever the policy is, they will not be involved. So vendor and the patients and doctors disconnect was a major thing. And the other thing is, whenever you try something new, or you have to implement a policy or a decision, like suppose we say that we have to implement IT in this institution, the first thing people will ask is for manpower, because they feel that without manpower nothing can be implemented in any institution. And because of this, I think majority of the implementations fail, because the manpower, when recruited new, people don't have job responsibilities for them defined well. So they will just sit there, become data entry operators, or will not know what to do. So again, I think, and it adds to the overall cost of the project, which actually does not serve any purpose. So the success of any implementation, I feel, is that rather than just being cost effective, it has to be finally usable by all stakeholders. That is the actual success. If you implement something and you show on paper that yes, we have implemented the software, we're getting results out of it, I don't think that is a success. If all stakeholders say that yes, it has affected our lives and it is making our things better, that is the final, I would say, the yardstick for defining successful implementation. So as I said, the buy-in by the hospital or any institution, this is generic because I am representing a hospital, I am saying a hospital, and the implementation has to be done by the institution. So you cannot depend on a vendor to do it. The vendor should only be responsible for training the trainers, customization or development of whatever the software or the processes, and nothing else. So it should be a very clear demarcation what you expect from the external or the third party. So I'll just take you through our case study of All India Institute. We started at Trauma Center, the implementation, and then we moved on to the whole of All India Institute. I'll just give you a brief statistics. At All India Institute, I just told the budget. We have more than 5,500 nurses in one campus, more than 1,500 doctors and ancillary staff, so that permanent staff at this institution is more than 13,000. So that's a huge number of staff which is positioned at one place, which requires constant education and training to make them, because every skill set will eventually become static and outdated unless you can have continuing education. So we have this huge numbers to deal with, and obviously we get around 3 million patients a year, that's 30 lakh patients a year, and with every patient we get 2-3 relatives. You can imagine the amount of numbers coming into that campus and the issues we have to face because of that. So firstly, a brief about public funded healthcare in general. This was a lead article in Times of India some times back, and if you see, they said that actually government hospitals are on life support themselves because of a lot of factors, and there is a lot of despair. You would not take your patient or yourself to any government hospital if you could have another option, and that's the sad fact of our country. So when we started with Trauma Center, we defined objectives. For anything to be successful or implemented, you have to first define what you really want out of it. And we said our primary objective was to improve transparency and accountability. So it's easier said than done, but I think that was what is affecting or ailing the healthcare system. The other priorities were to actually improve the satisfaction and delivery of services to patients in 2 key areas. One is the emergency department, which is because that's the face of the hospital, and the other is the clinics or the OPDs as we generally call them. So we deployed these strategies. These were our own, some of them were innovative, our own strategies, and I'll just quickly talk through them to tell you how education remains the key component in each strategy. So the call center. Now this is a very innovative concept. You've all heard of call centers. All these companies, major companies have call centers where they take the calls and the complaints. We said we'll have a call center for healthcare and for a hospital. Again, which was never tried before. So we did a tender and we had a call center set up. So people told me, why don't you just deploy more people in the hospital itself? They can answer the queries, do everything. So I said, first thing, in a government setup, any person you employ becomes a babu. Okay? So they will not be there on the seat, they will be doing something else. Be impolite to everybody who comes to them. And that's another sad aspect which I have seen for a long time, and I think it's a hint of colonialism which is there in each one of us, is that if you are behind the chair or a desk, you act that you have all the powers. And any person who comes, especially if that person is from the lower strata of the society, you would be treated like dirt. So even if the guard is there on the other side, he will treat the other person as dirt. So it's you see the whole system in front of you working, and the healthcare in a hospital, you can not see it better than there, how people get treated just by how they speak or how they wear clothes. And it's a telling pointer to what is ailing our education system. That this is a colonialism or some kind of a hierarchy we have imbibed from the British rule, which continues till date. So what we said that if we have people on premises, it's going to be the same, and the corruption is also going to be because people ask for money to get anything done. So that's why we started a call center, and the purpose of the call center are two. One, as soon as the patient comes into the hospital, the data is automatically sent to them, and they give a call to the number registered. So they give a call saying in Hindi or in English, depending on whatever is comfortable, that welcome to our AIMS, and in case you have any problems, you please. So they are educating the patient or the relative and empowering them that look, there is a feedback mechanism, there's a loop there, and it is not that you're going into a black hole, your voice can be heard. That's a huge empowerment for a person who doesn't know the system at all. And at the back end, we capture the phone number and we continue to call up these patients, fix appointments to make it a continuous process for them. The other thing is educating the lay public. See, what happens is, if I'm a patient and I want to get treated for any disease, even for backache or for disc or anything, I don't know the complication rate of a specific doctor. So if I go to a doctor and say he advises me surgery, I cannot ask the question, what is your complication rate? Forget the doctor, I don't even know the complication rate of the department of the hospital. So I think everybody is entitled for that knowledge, that if we go to what we have heard from hearsay or from other sources. So we decided that we will give our data on whatever is our complication rate for every disease or diagnosis online. So on a public website, we put up this data for the last 5 years, and I can tell you no hospital in the world does that. It's not that anybody does it, not even Harvard, not even any hospital in the world. And we say these are our complication rates for these diseases, and you can benchmark it against that. Tell us whether we are better or you're better. And I think that is the only way to improve the transparency and the accountability of a system. The other thing is we obviously we implemented the electronic medical record, PACS, and the electronic medical legal case sheets and everything. That is standard. We used open source, and it helped in the documentation, because nothing can be done in healthcare without the first step of documentation, and documentation in a format which can be analyzed. Whatever data we have, we just say it from the Western sources. We don't have our own data in the majority of even for road traffic accidents, if I tell you, we don't have data on what is the mortality, what is the complication rate. We just take it from the Western data. So unless you have proper documentation, that's what we started, we cannot get anywhere. The fourth thing is the patient display system. Again, this was for information of the patients as well as the doctors. Our director said, Deepak, I want a system like airline display system, where I can see every patient's information in real time, who is coming in the emergency department. So then we devised this system, so I hope it plays. So there is a big board or a billboard inside the emergency department at AIMS, and as soon as the patient comes in, there's a dedicated nurse, what we call as nursing informatics specialist. So there's a special cadre we have created. So a lot of things are automatic, a lot of things they're entering. So we are getting to know in real time when the doctor came and saw, when was the patient, every step, what is the status of the patient, what is he waiting for, and what is the next step. So all this is displayed on a giant display screen. So the couple of questions which I asked for me was the privacy issues, and for that it's a standard protocol in India that in case of any emergency, privacy takes a backseat. For emergency department especially, or a disaster or anything, because unless you display the names, nobody would be able to find these patients, So you can't have confidentiality in the emergency scenario. The second thing is, if the patients are illiterate, how will they read the board? So this is not for the patients only. It is for the doctors and nurses in a busy emergency department. If you want to know the status of a patient, they cannot go to the every file and check it out. So they can just look at the board and tell this is the status, what we're going to do next about it. So this is, and at the back end, we are actually collecting the data, educating us about how long it is taking for a doctor to see a patient, how long it is taking for an X-ray to be done, a CT to be done. All this data we are compiling and benchmarking against our own times so that we can improve ourselves. So I think the reasons for our success were, one is using our existing manpower, and the cadre we deployed, the nursing informatics, has been really very useful to us, because this cadre of nurses, we have 100 of them now, actually go and do the training part also. So what is the training for all the 7,000 staff is, we have created an online platform on Moodle, that's an open source software, and we created modules on various topics, and mandated that every healthcare worker, be it a nurse or a doctor, has to take these modules on a continuous basis, and we grade them, and then if they do not pass, then we put a remark in the service log. So I think that is again a model, the way forward for continuing education for health, because that is very important, not only at our institution but any institution across the country. The second thing is to buy-in of the stakeholders. You have to have high visibility of whatever you're doing. So we, as I said, we put in those huge billboards or the display boards. We have the online system, we have the so unless people see what is happening, they will not buy in. So for any, I would say any endeavor which you do, there should be a continuous information to all stakeholders on the what is the progress, what is the success, and what is the actual happening. So I take extreme pride in saying that if you look at the trauma center, I hope none of you has to ever come there as a patient, but as a visitor you're most welcome. It is one of the cleanest and most well-maintained public hospitals in India, and obviously one of the most IT enabled. And we replicated this model in less than 3 years to whole of AIIMS, which is around 3,000 beds. And when we introduced the appointment system, the online appointment system, see what happened was, this was our own innovation, but it reached the top level.
रक्षा राज्य मंत्री डॉक्टर सुभाष
So this
भामरे,
was Prime Minister Modi
रक्षा
on
सचिव
the
श्री जी
Independence
मोहन
Day,
कुमार,
and to our surprise, he actually commented on our system.
देशवासियों, आजादी के इस पावन पर्व पर 125 करोड़ देशवासियों को, विश्व में फैले हुए सभी भारतीयों को लाल किले की प्राचीर से बहुत बहुत शुभकामनाएं देता हूं। हमें याद है कि वो भी एक दिन थे जब किसी बड़े अस्पताल में जाना हो तो कितने दिनों तक इंतजार करना पड़ता था। एम्स में लोग आते थे, 2-2, 3-3 दिन बिताते थे, तब जाकर के कब उनको जांचा परखा जाएगा उसका तय होता था। आज उन सारी व्यवस्थाओं को हम बदल पाए हैं। ऑनलाइन रजिस्ट्रेशन होता है, ऑनलाइन डॉक्टर की अपॉइंटमेंट मिलती है, तय समय पर पेशेंट आए तो उसका काम शुरू हो जाता है। इतना ही नहीं, उसके सारे मेडिकल रिकॉर्ड भी उसको ऑनलाइन उपलब्ध होते हैं। और हम इसको आरोग्य के क्षेत्र में देशव्यापी एक कल्चर के रूप में विकसित करना चाहते हैं। आज सरकार के बड़े बड़े 40 से अधिक अस्पतालों में इस व्यवस्था को किया है, लेकिन
So I think the biggest success is not you telling it about yourself, but other people espousing it. And it gave us immense pleasure that he actually committed that he would want a national implementation of whatever our model is across India. And we already have a MOU to have the same thing implemented across AIIMS, and we got a lot of awards for that. So thank you so much for the patient listening.
Thank you so much to Dr. Deepak Agarwal. And now once again I request Mr. Amit Kumar to please come on the stage and present a memento to Dr. Deepak Agarwal as a token of love. And can we have a big round of applause for Dr. Deepak Agarwal?